Hello and welcome to your ultimate guide for the ATI Maternal exam. My goal today is simple: give you everything you need to fully understand the key concepts, master them, and walk into your ATI Maternal exam with total confidence. In this video we'll cover postpartum care, newborn interventions, labour complications, prenatal assessment, fetal monitoring. With over 100 plus success stories, we have proven our videos will help you pass your exam on the first attempt. And remember, our website offers free exam guides and practice questions to help you ace your ATI Maternal exam. You'll find the link in the description below, so be sure to check it out and get the resources you need to study smarter, not harder. So let's get started.
Question 1. A nurse is caring for a client several weeks after birth who has persistent sadness and loss of interest that have not improved. Which condition should the nurse suspect? Your options are A. Postpartum blues, B. Normal adjustment, C. Postpartum depression, D. Taking hold phase. Which one is it? Pause the video if you need more time. The correct answer is C. Postpartum depression. C is correct because persistent sadness and loss of interest that do not resolve on their own suggest postpartum depression, which usually requires treatment rather than passing like the blues. A is wrong because postpartum blues are brief and self-limiting, unlike these persistent symptoms. B is wrong because ongoing, worsening sadness goes beyond normal adjustment to a newborn. D is wrong because the taking hold phase is a stage of learning newborn care, not a mood disorder. After childbirth, mood changes exist on a spectrum, from a brief, expected dip to a genuine depressive illness that requires treatment. Understanding where one ends and the other begins is what clinical practice demands. There are 3 distinct points on this spectrum. The blues are transient and self-resolving. Postpartum depression persists and worsens beyond 2 weeks. Postpartum psychosis is a rare psychiatric emergency involving hallucinations or delusions. The key distinction is self-resolution. Blues lift on their own. The parent still functions and finds moments of joy. Depression does not lift. Sadness deepens. Interest in the baby drains away. And sleep and appetite remain disturbed beyond what a newborn schedule explains. The biology behind this is real. The placenta's delivery causes estrogen and progesterone to fall sharply within 1 to 2 days. Hormonal cliff that, combined with sleep deprivation and identity shift, creates the conditions for mood disruption. When a scenario shows sadness that has not budged past 2 weeks, with loss of interest and withdrawal, that is not normal adjustment. It is postpartum depression, and it warrants screening and referral, not reassurance. Question 2. A nurse is caring for a newborn receiving phototherapy for hyperbilirubinemia under the lights. Which action should the nurse take while the newborn is being treated? Your options are A. Cover the newborn's eyes with a mask, B. Keep the newborn in one position, C. Apply lotion to the skin, D. Dress the newborn warmly. Take a second. Which answer would you pick? The correct answer is A. Cover the newborn's eyes with a mask. A is correct because during phototherapy, the nurse covers the newborn's eyes to protect them, keeps the newborn undressed for skin exposure, and repositions frequently for even treatment. B is wrong because the newborn is repositioned regularly, so all skin areas are exposed to the light. C is wrong because lotions can absorb heat and cause burns under the lights. D is wrong because the newborn is kept undressed so the light reaches the skin to break down bilirubin. When bilirubin builds up faster than a newborn's immature liver can clear it, the pigment settles into the skin and can rise to levels that threaten the brain. Phototherapy uses controlled blue spectrum light to fix this, not by supporting the liver, but by chemically transforming the bilirubin itself. Blue spectrum light penetrates the skin and reshapes bilirubin into water-soluble forms. Yup, lumirubin and photobilirubin, that the body can excrete through bile and urine without the liver processing them first. The single conversion is the entire mechanism behind every bedside decision. 4 priorities anchor the care plan. Maximum skin must be exposed so light reaches as much bilirubin as possible. Opaque eye shields protect the developing retina. No lotions or creams are applied because a film under a warm lamp traps heat and risks burns. And frequent feeds replace fluid loss through the warm environment and loose stools. Repositioning the newborn every few hours rotates fresh skin under the lamps, keeping conversion even across the whole body rather than concentrate on one surface. The more uniformly skin is exposed, the more consistently bilirubin levels fall. The instinct to bundle a jaundiced newborn to keep it warm directly defeats treatment. Temperature is managed by monitoring the warmer, never by adding clothing that blocks the light. Expose the skin, shield the eyes, and keep the baby well fed and hydrated. Question 3. A nurse is caring for a newborn who has mucus in the mouth and nose. Which action should the nurse take to clear the airway? Your options are: A. Compress the bulb after insertion. B. Insert the bulb deep into the throat. C. Suction the mouth before the nose. D. Suction the nose before the mouth. Before I reveal it, which one do you think is right? The correct answer is C. Suction the mouth before the nose. C is correct because the nurse suctions the mouth before the nose. Because suctioning the nose first can cause the newborn to gasp and aspirate secretions from the mouth. A is wrong because the bulb is compressed before insertion, then released to gently draw out secretions. B is wrong because inserting the bulb deeply can stimulate the gag reflex and injure tissue. D is wrong because suctioning the nose first can trigger a gasp that draws mouth secretions into the lungs. Clearing a newborn's airway with a bulb syringe is a skill built on precise sequencing. Newborns are obligate nose breathers with weak, uncoordinated gag and swallow reflexes. So, the order in which you suction determines whether you protect the lungs or accidentally threaten them. 3 principles govern safe suctioning. First, always clear the mouth before the nose. Second, compress the bulb before insertion, never after. Third, keep the tip shallow, aimed at the cheek pocket, not the throat. Here is why mouth before nose matters. Suctioning the nose triggers a sharp reflexive gasp. If the mouth still holds secretions when that gasp fires, the inrushing air pulls them straight into the trachea. Clearing the mouth first removes the reservoir, so the gasp inhales only air. Depth matters equally. The bulb tip stays at the cheek pocket and front of the mouth. Inserting it too deep stimulates the gag reflex and can provoke a vagal response, slowing the newborn's heart. Gentle, shallow suction captures the secretions that actually threaten the airway. The memory hook is simple. M comes before N, mouth before nose. Compress the bulb outside, release inside, and never go deep. Follow the sequence and the newborn's first breaths stay clear. Question 4. A nurse is teaching a client in the supine position who suddenly feels dizzy, pale, and clammy late in pregnancy. Which action should the nurse take? Your options are: A. Have the client sit upright. B. Give oxygen by face mask. C. Raise the head of the bed. D. Turn the client onto her side. What's your answer? Commit to one before I continue. The correct answer is D. Turn the client onto her side. D is correct because these findings suggest the heavy uterus is compressing the major vessel and reducing blood return. So turning the client to her side relieves the pressure and restores circulation. A is wrong because sitting upright fails to shift the uterus away from the vessel and may not relieve the dizziness quickly. B is wrong because oxygen does not address the underlying cause. which is mechanical pressure that sideline relieves directly. C is wrong because raising the head does not move the uterus off the compressed vessel, so the low blood pressure would continue. Supine hypotensive syndrome is a mechanical problem that strikes late in pregnancy, the moment a client lies flat on her back. Understanding why it happens makes the correct response obvious and immediate. By the third trimester, the uterus is large and heavy. When the client lies supine, that weight presses directly onto the inferior vena cava, the major vein returning blood from the lower body to the heart, and to a lesser degree onto the aorta. This compression is called aortocaval compression. Less blood reaching the heart means less blood pumped out. Cardiac output drops. Blood pressure falls, and the client experiences the classic signs of low perfusion: dizziness, lightheadedness, pale and clammy skin, and sometimes nausea. Crucially, placental blood flow also decreases, which can alter the fetal heart rate. The correction follows directly from the cause. Tilting the client onto her left side rolls the uterus off the vena cava. Venous return is restored. Cardiac output recovers, and symptoms ease within moments. A small wedge under one hip achieves the same effect whenever a pregnant client must lie down for an examination. Oxygen, sitting upright, or raising the head of the bed each address a surface symptom while leaving the uterus parked on the vessel. Only moving the uterus off the vena cava solves the actual cause, and that is always the answer. Question 5. A nurse is monitoring a client in labor and notes the resting tone of the uterus stays firm, with no relaxation between contractions. Which complication should the nurse monitor for? Your options are: A. Lower risk of bleeding. B. Faster cervical healing. C. Reduced fetal oxygenation. D. Improved fetal oxygenation. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is C. Reduced fetal oxygenation. C is correct because the fetus receives the most oxygen when the uterus relaxes between contractions. So a uterus that does not relax raises the risk of reduced fetal oxygenation. A is wrong because excessive uterine activity can lead to complications rather than lowering bleeding risk. B is wrong because constant uterine tone does not speed healing and instead endangers the fetus. D is wrong because the lack of relaxation decreases, rather than improves, fetal oxygen delivery. The resting tone of the uterus, how relaxed the muscle is between contractions, is one of the most important signals in labor monitoring. Understanding why explains how the fetus actually receives its oxygen. Spiral arteries thread through the uterine muscle wall to supply the placenta. When the muscle contracts, it pinches those vessels and briefly cuts blood flow into the intervillous space. When the muscle relaxes, the vessels reopen and oxygenated blood refills that space. This is when the fetus gets its oxygen. The fetus tolerates brief vessel compression during each contraction because it knows a refill is coming. The contraction does the work, but the relaxation is the recovery window, the moment the intervillous space refills and the fetus takes its deepest breath. If the uterus never fully relaxes, due to tachycystole, oxytocin excess, or prolonged tension, the spiral arteries stay compressed between contractions. The intervillous space cannot refill. Oxygen debt accumulates with every passing minute, and the fetal heart rate reflects the compromise. A firm, unrelenting uterus is never a sign of progress, it is a warning. The goal is always to restore the rest periods the fetus depends on to reoxygenate. Constant firmness means reduced fetal oxygenation, full stop. Question 6. A nurse is assessing a newborn and notes bluish-grey flat areas over the lower back and buttocks. Which action should the nurse take? Your options are: A. Document the finding. B. Apply a warm compress. C. Report suspected injury. D. Restrict the newborn's movement. Which would you go with? Lock it in before the reveal. The correct answer is A. Document the finding. That is correct because flat bluish-grey areas over the back and buttocks are Mongolian spots, a normal newborn finding, so the nurse simply documents them to avoid later confusion with bruising. B is wrong because a warm compress is not needed for this harmless skin finding. C is wrong because these spots are a normal pigmentation finding, not a sign of injury to report. D is wrong because the spots do not affect movement and require no activity restriction. Mongolian spots, now called congenital dermal melanocytosis, are flat blue-grey patches found most often over the lower back and buttocks of newborns. The single most important fact is that they are a normal variation in pigmentation, not a bruise, not an injury, and not a disease. The blue-grey color forms because some melanocytes get trapped in the deeper dermal layer during development instead of completing their migration to the surface. Light scattering through the overlying skin reads that deep pigment as blue or slate grey, the same optical effect that makes deep veins look blue. Two features separate Mongolian spots from anything worrisome. They are flat with no swelling, warmth, or tenderness, and they are present from birth rather than appearing after trauma. A true bruise is tied to injury and cycles through purple, green, and yellow as blood breaks down, while a Mongolian spot holds its color steadily and fades slowly over the first years of childhood. Documentation is the action that matters, because these patches can resemble bruising to someone unfamiliar with them. Recording their location, size, and appearance at birth creates a clear record that the marks are a normal finding. That note protects the family and prevents a benign birthmark from being misread as a sign of harm at a later examination by a different clinician. The signal phrases to recognize are flat, blue-grey, lower back and buttocks, and present at birth. Each wrong response, applying a compress, reporting injury, or restricting movement, shares the same error, treating a harmless variation as though it were pathology. Question 7. A nurse is caring for a client in preterm labor at 30 weeks of gestation who is prescribed betamethasone. How should the nurse explain the purpose of this medication? Your options are A. It lowers the client's blood pressure. B. It treats an infection. So it speeds the baby's lung development. D. It stops the contractions. Don't overthink it. Which one feels right? The correct answer is C. It speeds the baby's lung development. C is correct because betamethasone is a glucocorticoid that speeds fetal lung development and surfactant production, which helps the newborn breathe if an early birth occurs. A is wrong because the medication targets fetal lung maturity, not the client's blood pressure. B is wrong because betamethasone is a steroid for lung maturity, not an antibiotic for infection. D is wrong because betamethasone does not stop contractions. Separate tocolytic medications are used for that purpose. Betamethasone is an antenatal steroid given during preterm labor with one specific goal: accelerating fetal lung maturation before an early birth. It does not stop contractions, lower blood pressure, or treat infection. That is the job of entirely different drugs. The problem betamethasone solves is surfactant, a substance that lines the tiny air sacs of the lungs and keeps them from collapsing shut after each breath. The fetus does not produce reliable surfactant until late in pregnancy, leaving premature lungs vulnerable to respiratory distress syndrome. Crossing the placenta from the mother, the steroid reaches fetal lung tissue and accelerates a developmental step that would otherwise take more time. The benefit is greatest when there is a window of roughly 1 to 2 days between the dose and the birth, enough time for the surfactant response to build. The most common mix-up is assuming any drug given in preterm labor must be stopping contractions. That is the tocolytic's role. Betamethasone and a tocolytic are often paired. The tocolytic buys time, and the steroid uses that time to mature the lungs. Each drug has its own distinct target. Whenever you see betamethasone and preterm labor together, the reasoning is straightforward. An antenatal steroid speeds fetal lung development for an anticipated early birth, lowering blood pressure, stopping contractions, and fighting infection are all real obstetric goals, just not this drug's goal. Question 8. A nurse is caring for a client receiving an oxytocin infusion. At which site on the intravenous line should the nurse connect the oxytocin? Your options are A. The port farthest from the client, B. Any available port on the line, C. A separate line in the other arm, D. The port closest to the client. Got a guess? Lock it in. The correct answer is D. The port closest to the client. D is correct because oxytocin is connected to the port closest to the client and given by pump, so the infusion can be stopped quickly with little remaining medication if a problem occurs. A is wrong because the farthest port leaves more medication in the line, delaying how fast it can be stopped. B is wrong because the specific closest port is chosen for safety, not any port at random. C is wrong because oxytocin is given as a secondary infusion into the main line, not a separate independent line. When oxytocin is used to start or strengthen labor, every detail of how it connects to the IV line is chosen to allow the fastest possible shut-off. Understanding why requires looking at what sits inside the tubing. Oxytocin runs as a secondary infusion through a pump and connects at the port nearest the client. That placement minimizes the column of drug-filled tubing between the connection point and the vein. So when the pump stops, almost no drug remains downstream to keep draining in. A short downstream column means the drug effect begins to fade almost immediately after the pump is paused. That speed is critical because oxytocin can drive uterine overactivity, contractions too close together, or a uterus that won't relax, cutting into the fetal oxygen supply. The setup is deliberate at every level. A secondary infusion keeps fluids running after the drug stops. A pump ensures precise dosing. And the proximal port together with the pump gives the nurse the fastest possible way to halt a high alert drug when the fetal monitor turns concerning. Any variation, a farther port, a separate line, gravity instead of a pump, lengthens the time oxytocin keeps acting after it is stopped. The right setup is designed from the start for the moment you need to stop fast. Question 9. A nurse is supporting a couple who just learned they are experiencing infertility. Which nursing action is most appropriate? Your options are A. Encourage them to express their feelings. B. Reassure them it will resolve. C. Suggest they adopt instead. D. Tell them to relax and wait. Which one is it? Pause the video if you need more time. The correct answer is A. Encourage them to express their feelings. A is correct because infertility is a significant life stressor that brings grief and strain. So allowing the couple to talk openly about their feelings supports coping and guides further care. B is wrong because false reassurance dismisses the couple's distress and promises an outcome the nurse cannot guarantee. C is wrong because steering the couple toward adoption ignores their current feelings and removes their right to weigh options themselves. D is wrong because telling the couple to simply relax minimizes a real medical concern and offers no genuine support. When a couple first learns they are facing infertility, the nurse's most important role is not to advise or reassure, it is to open space for their feelings. Infertility is a loss, and it carries grief, guilt, and relational strain that deserve to be named and heard. Infertility is not just a medical diagnosis. It arrives with the same emotional weight as bereavement, and those emotions need a place to land before any clinical conversation can be meaningful. When a nurse invites a couple to share how they are feeling, three things happen at once. The couple feels seen rather than processed. The nurse learns what the couple actually understands and fears, and the act of speaking the grief aloud begins the work of coping with it. The traps are the well-meaning responses that close the conversation down. False reassurance. Jumping to solutions like suggesting adoption and telling the couple to relax all minimize real distress and quietly remove the couple's right to feel and process what they are experiencing. Therapeutic communication begins by following the client's lead. A nurse who tolerates silence, asks open questions, and stays present in the sadness offers the couple something more useful than advice or reassurance ever could. Question 10. A nurse strokes the outer sole of a newborn's foot upward and the toes fan out and upward. How should the nurse interpret this finding? Your options are it is an abnormal finding to report. B, it is an expected Babinski reflex. C, it indicates a nervous system injury. D, it signals a hip problem. Take a second. Which answer would you pick? The correct answer is B. It is an expected Babinski reflex. B is correct because fanning of the toes when the sole is stroked is a normal Babinski reflex in the newborn, which is expected and disappears later in infancy. A is wrong because the Babinski reflex is expected at this age and does not need reporting. C is wrong because this response is normal in newborns rather than a sign of injury. D is wrong because this reflex assesses neurologic response, not the hips. The Babinski reflex is one of several primitive reflexes nurses assess at birth. Understanding it correctly means knowing that the same response carries completely opposite meanings depending on the age of the person showing it. When the outer edge of a newborn sole is stroked, the big toe bends upward and the smaller toes fan out. In an adult, that identical response signals nerve pathway damage, but in a newborn, it is the healthy, expected result. The reflex exists because a newborn's nerve fibers are not yet fully wrapped in myelin, the fatty insulation that speeds and refines signals. Without mature myelination, the brain has not yet taken full control over spinal reflexes. So the upgoing toe is simply the default. Over the first 1 to 2 years, myelination completes and the response flips to the adult downward curl. That developmental timeline is the key. Toes fanning upward in a newborn signals an intact age-appropriate nervous system. The exact same fanning in an older child or adult signals damage to the nerve pathways, because by that age the reflex should have disappeared. A reflex present on schedule is reassuring, and one that lingers past its expected window is what prompts concern. The Babinski finding is not abnormal in itself. Its meaning belongs entirely to the developmental stage of the person showing it. Question 11. A nurse is teaching parents about supplementing a breastfed newborn with vitamin D. Which statement should the nurse include? Your options are A. Breast milk supplies all vitamin D. B. Vitamin D is harmful to newborns. C. Breastfed newborns need vitamin D drops. D. Vitamin D is needed only in winter. Before I reveal it, which one do you think is right? The correct answer is C. Breastfed newborns need vitamin D drops. C is correct because breast milk is low in vitamin D. So breastfed and partially breastfed newborns receive a daily vitamin D supplement to support bone development. A is wrong because breast milk does not provide enough vitamin D, which is why a supplement is given. B is wrong because the recommended vitamin D supplement is beneficial, not harmful. D is wrong because the supplement is given daily year-round, not only in winter. Breast milk is one of nature's most complete foods, but it has one well-known gap. it is low in vitamin D. That single shortfall makes a daily supplement necessary for breastfed newborns from the very first days of life. Vitamin D controls how the body absorbs calcium and phosphorus, the minerals that harden growing bone. Without enough of it, bones can soften and bend, the condition known as rickets. While breast milk delivers proteins, fats, antibodies, and sugars in abundance, vitamin D is consistently low. A daily supplement, typically given as drops, fills that gap and ensures calcium reaches the developing skeleton. Humans evolved to produce vitamin D through sun exposure, but newborns are rightly kept out of direct sunlight because their thin skin burns easily. With both the skin route and the milk route falling short, a daily supplement is the reliable solution. The recommended dose is 400 international units per day, given year-round, not just in winter, because infants stay out of direct sun in every season. This preventive supplement supports normal bone development before any problem has a chance to appear. Question 12. A nurse is reviewing the record of a pregnant client who is not immune to rubella. Which action should the nurse plan? Your options are: A. Begin antiviral medication now. B. Repeat the tutor weekly. C. Give the vaccine this visit. D. Give the vaccine after birth. What's your answer? Commit to one before I continue. The correct answer is D. Give the vaccine after birth. D is correct because the rubella vaccine is a live virus and is not given during pregnancy. So a non-immune client is vaccinated after birth to protect future pregnancies. A is wrong because antiviral medication is not the plan for rubella non-immunity. Vaccination after birth is. B is wrong because repeating the titer weekly serves no purpose when the plan is simply to vaccinate after delivery. C is wrong because giving a live vaccine during pregnancy is avoided due to potential risk to the fetus. When a pregnant client is found to be non-immune to rubella, the vaccine is not given right away. The rule is firm. Live virus vaccines are never administered during pregnancy. Instead, vaccination waits until the postpartum period. A live, attenuated vaccine uses a weakened but living form of the virus. During pregnancy, even a weakened live virus carries a theoretical risk of reaching the fetus. Natural rubella infection is far more dangerous, causing congenital defects of the heart, eyes, ears, and brain. So the safest approach is simply to wait. Natural rubella infection early in pregnancy targets 4 critical structures in the developing fetus: the heart, the eyes, the ears, and the brain. These defects, known collectively as congenital rubella syndrome, are the reason the standard of care is so strict about avoiding any live virus exposure during pregnancy. Early in prenatal care, a blood test checks for rubella antibodies. A non-immune client is flagged, avoids exposure throughout pregnancy, and receives the live vaccine after birth before discharge. One key teaching point: avoid becoming pregnant again for about 1 month after the dose to allow the live virus to clear. The takeaway is straightforward. A non-immune pregnant client does not receive the rubella vaccine during pregnancy. She receives it postpartum, protecting all future pregnancies without any risk to the current one. Question 13. A nurse is counseling a client who wants the most effective reversible method of birth control. Which method should the nurse recommend? Your options are: an intrauterine device, B. a diaphragm, C. the calendar method, D. male condoms. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is A. an intrauterine device. A is correct because long-acting reversible methods such as the intrauterine device are the most effective because they work continuously and do not depend on the client remembering to act each time. B is wrong because a diaphragm works only when fitted properly and paired with spermicide each time, so its real-world effectiveness falls below an intrauterine device. C is wrong because the calendar method relies on predictable cycles and careful timing of abstinence, which makes it one of the least dependable options. D is wrong because condoms guard against sexually transmitted infections but carry a higher failure rate since protection depends on correct use during every act. When a client needs the most effective reversible birth control, the answer comes down to one core principle: removing human error from the equation. Long-acting reversible contraception, with the intrauterine device as its prime example, achieves this better than any other reversible method. Contraceptive effectiveness has two measures. Perfect use reflects flawless performance. Typical use reflects real life. Methods requiring a daily pill or a correctly placed condom lose ground in typical use. The IUD nearly eliminates that gap because once inserted, there is no recurring action to forget. The IUD sits inside the uterus and creates an environment hostile to fertilization, either through locally released hormones or copper that interferes with sperm. It stays effective for several years, up to about a decade, yet the moment it is removed, fertility returns promptly. The other reversible methods each carry a weakness tied to use. The pill requires daily memory. The condom provides critical STI protection but depends on correct use every encounter. The calendar method relies on predictable cycles and disciplined timing, making it among the least dependable options. The signal phrases to watch for are most effective, reversible, and no ongoing user action. Long-acting reversible contraception wins because it takes human imperfection out of the picture entirely. That is the reasoning that points to the IUD. Question 14. A nurse is performing Leopold maneuvers on a pregnant client. Which action should the nurse take before beginning? Your options are: A. Offer the client a large meal. B. Have the client empty her bladder. C. Place the client flat on her back. D. Position the client standing. Which would you go with? Lock it in before the reveal. The correct answer is B. Have the client empty her bladder. B is correct because asking the client to empty her bladder first improves comfort and makes it easier to palpate the fetal position, since a full bladder can interfere with the examination. A is wrong because a large meal does not aid palpation and may add to the client's discomfort during the examination. C is wrong because lying completely flat can compress the major vessel. A small wedge under one hip is used to prevent low blood pressure. D is wrong because Leopold maneuvers are performed with the client lying down, not standing, so the abdomen can be palpated. Leopold maneuvers are 4 systematic abdominal palpations that map fetal position, lie, and presentation entirely by touch. Before the examination begins, one preparatory step makes everything that follows more accurate and more comfortable. The reason is mechanical. A full bladder sits low in the abdomen directly over the area the nurse needs to feel. It distorts the landmarks, blocks deep palpation, and causes discomfort. Emptying it removes that obstruction, so fetal parts become clearly distinguishable under the examining hands. The examination moves through 4 stations. The first identifies which fetal pole occupies the upper uterus. The second locates the back and small parts along the sides. The third confirms the presenting part just above the pubic bone. The fourth assesses how far that part has descended into the pelvis. Positioning supports the procedure. The client lies supine with the head slightly raised and knees gently bent to relax the abdominal muscles. A wedge under one hip tilts the uterus off the major vessels, preventing the supine drop in blood pressure that flat positioning can cause. Standing, lying completely flat, or eating a large meal beforehand each undermine the examination in different ways. Only emptying the bladder directly improves both accuracy and comfort, a small step that makes every maneuver that follows more effective. Question 15. A nurse is assessing parent-newborn interaction and notes the parent handles the newborn roughly and shows little interest. Which nursing action is most appropriate? Your options are A. Ignore the behavior as normal. B. Tell the parent they are failing. C. Continue to assess and support bonding. D. Remove the newborn permanently. Don't overthink it. Which one feels right? The correct answer is C. Continue to assess and support bonding. C is correct because signs of weak attachment call for ongoing assessment and supportive interventions that encourage interaction, rather than judgment, to strengthen the developing bond. A is wrong because these behaviors are warning signs of impaired bonding, not normal responses to ignore. B is wrong because telling the parent they are failing is shaming and undermines the bonding the nurse is trying to build. D is wrong because the nurse supports bonding rather than removing the newborn based on early observations. After birth, one of the nurse's most important roles is watching how the emotional bond between parent and newborn begins to form. This bond shapes the child's safety and development for years to come. Healthy bonding has concrete visible signs. A parent who is attaching well makes eye contact, holds the baby close, speaks to it, uses its name, and responds to its cues. Flat, affect, rough handling, or turning away signal the process may be faltering. Many things can stall early bonding, and most say nothing about the parent's character. Exhaustion, pain, a difficult birth, postpartum mood changes, or simply having no role models to draw from can all dampen the early response. Because the causes are varied and often fixable, judgment is not the right lens. Supportive interventions are practical, encouraging skin-to-skin contact, modeling gentle handling, pointing out the baby's responses, praising small steps, and screening for postpartum depression all help the relationship grow. Ongoing assessment runs alongside these steps so the nurse knows whether the bond is strengthening. There are 3 traps to avoid. Ignoring the behavior misses a genuine warning sign. Shaming the parent damages the very bond you're trying to build. Removing the newborn too early abandons the supportive work that early concerns actually call for. The right path is to continue assessing and supporting. Question 16. A nurse is caring for a client whose fetal monitor shows moderate variability in the fetal heart rate baseline. How should the nurse interpret this finding? Your options are A. It indicates cord prolapse. B. It signals fetal hypoxia. C. It requires stopping labor. D. It is a reassuring finding. Got a guess? Lock it in. The correct answer is D. It is a reassuring finding. D is correct because moderate variability of the fetal heart rate baseline is reassuring, reflecting a well-oxygenated fetus with an intact nervous system, so no intervention is required. A is wrong because cord prolapse produces sudden decelerations, not reassuring moderate variability. B is wrong because absent or minimal variability, not moderate variability, raises concern for hypoxia. C is wrong because a reassuring pattern supports continuing labor rather than stopping it. Fetal heart rate variability is one of the most informative signs on a fetal monitor. Understanding what drives it and what it means helps clinicians tell a normal tracing from a concerning one. The fetal heart is under constant push and pull from the autonomic nervous system. The sympathetic branch nudges the rate up while the parasympathetic branch eases it down. This continuous tug of war between the two branches produces the small, irregular fluctuations visible on the monitor strip. Moderate variability is defined as a fluctuation range of 6 to 25 beats per minute around the baseline. It signals adequate fetal oxygenation and confirms that the neurologic pathways from brain to heart are intact. When variability falls in this range, no intervention is required. The finding itself is evidence of well-being. The contrast is what makes the finding meaningful. A gently jagged tracing is a moderate variability that reflects a healthy oxygenated fetus. A tracing that flattens out, showing minimal or absent variability, raises concern that the nervous system is not getting the oxygen it needs. The jagged line is the reassuring one. The flat line is the worry. Moderate variability is a live readout of fetal oxygenation and neurologic function. A wavy, fluctuating baseline is the healthy pattern, not a smooth, flat one. When you see moderate variability, continue monitoring with confidence. Question 17. A nurse is reviewing the result of a non-stress test that is documented as reactive. How should the nurse interpret this finding? Your options are it is a reassuring result. B. The fetus is in distress. C. Labor should be induced. D. A cesarean is needed. Which one is it? Pause the video if you need more time. The correct answer is A. It is a reassuring result. A is correct because a reactive non-stress test shows the fetal heart rate accelerating appropriately with movement, which is a reassuring sign of fetal well-being and an intact nervous system. B is wrong because a reactive result is normal and indicates the fetus is doing well, not that it is in distress. C is wrong because a reassuring test points to fetal well-being and does not signal a need to induce labor. D is wrong because a reactive result supports continuing the pregnancy and does not indicate that a cesarean is required. The non-stress test is a simple, non-invasive way to assess fetal well-being late in pregnancy. Understanding what makes a result reactive and why helps you interpret any NST tracing with confidence. When a healthy, well-oxygenated fetus moves, the autonomic nervous system briefly drives the heart rate upward, producing an acceleration on the tracing. This response requires both an intact nervous system and adequate oxygen, exactly the conditions that signal fetal well-being. For a term fetus, a reactive result requires accelerations of at least 15 beats per minute above the baseline, each lasting at least 15 seconds, occurring at least twice within a 20-minute period. Meet those criteria and the test is reactive, a reassuring sign. A reactive tracing means the natural link between movement and a rising heart rate is working. No intervention needed. A non-reactive tracing does not prove a problem, but it does prompt further evaluation to take a closer look. Remember, reactive is good news. A tracing that shows accelerations with fetal movement confirms adequate oxygenation and a working nervous system, a reason to continue monitoring, not to intervene. Question 18. A nurse is assessing a newborn for sepsis. Which finding should the nurse recognize as an early but subtle sign? Your options are A. Brisk, eager feeding. B. Temperature instability and poor feeding. C. Steady weight gain. D. A strong, vigorous cry. Take a second. Which answer would you pick? The correct answer is B. Temperature instability and poor feeding. B is correct because newborn sepsis often presents with subtle signs such as temperature instability, poor feeding, and lethargy. So these findings prompt cultures and prompt treatment. A is wrong because eager feeding is reassuring, whereas poor feeding suggests sepsis. C is wrong because steady weight gain reflects health rather than infection. D is wrong because a strong cry is a sign of well-being, not sepsis. Newborn sepsis is a serious bloodstream infection that can be dangerously easy to miss. Unlike older children, newborns cannot mount dramatic, localized signs of infection. The clues are soft, general, and easy to overlook. The root cause is an immature immune system. A newborn's body cannot reliably mount a fever and may instead show a dropping or unstable temperature. Responses are blunted and nonspecific. There is no clear fever and no clear source. Just a baby who is simply not doing well. The classic early warning signs are temperature instability, poor feeding, lethargy or difficulty rousing, and subtle changes in color or breathing. None of these alone is dramatic, and that is exactly the point. Together, they form a pattern the nurse must recognize and act on. Contrast helps sharpen the pattern. Vigorous feeding, a strong cry, and steady weight gain all point to a thriving baby. The opposite picture from early sepsis. Recognizing what health looks like makes the quiet warning signs easier to catch. Because the signs are quiet and the stakes are high, the response is prompt. Subtle findings trigger blood cultures and early antibiotics, often before results return. Catching sepsis at the stage of temperature, instability, and poor feeding, rather than at obvious collapse, is what changes the outcome. Question 19. A nurse is assessing a client on the second day after birth who reports calf pain with redness and warmth in one leg. Which action should the nurse take? Your options are: A. Massage the affected calf. B. Encourage vigorous leg exercises. C. Notify the provider and avoid massage. D. Apply firm pressure to the calf. Before I reveal it, which one do you think is right? The correct answer is C. Notify the provider and avoid massage. C is correct because unilateral calf pain with redness and warmth suggests a deep vein thrombosis, so the nurse notifies the provider and avoids massaging the leg, which could dislodge a clot. A is wrong because massaging the calf can dislodge a clot and cause a pulmonary embolism. B is wrong because vigorous exercise of the affected leg can also dislodge a clot. D is wrong because applying pressure to the calf does not treat a clot and risks dislodging it. After birth, the body enters a window of elevated clotting risk. A clot forming in a deep leg vein. A deep vein thrombosis can be silent at first, but the classic signs in one calf demand immediate attention and a very specific response. Pregnancy itself primes the blood to clot more readily, a protective adaptation that limits delivery blood loss. Add reduced movement, sustained pressure on the pelvic veins, and the vascular stress of childbirth, and the first postpartum days become a prime window for clot formation. Because veins carry blood back towards the heart and onward to the lungs, a fragment that breaks free travels straight to the pulmonary circulation. That blockage, a pulmonary embolism, can cause sudden chest pain, shortness of breath, and collapse. The clot's location in the venous highway is exactly what makes dislodging it so dangerous. Massaging the calf is the most direct danger, but vigorous leg exercises and firm pressure carry the same risk. Each disturbs the clot and can turn a leg problem into a lung emergency. The instinct to rub a sore, swollen leg is precisely the instinct that must be overridden. When one calf is painful, red, and warm after birth, the nurse keeps the leg undisturbed, notifies the provider, and anticipates anticoagulation and diagnostic workup. Never massage a suspected clot. Report it and leave it alone. Question 20. A nurse is preparing to assign APGAR scores to a newborn. At which time should the nurse perform these assessments? Your options are: A. Every 15 minutes for an hour. B. Only once at admission. C. At 30 and 60 minutes. D. At 1 and 5 minutes after birth. What's your answer? Commit to one before I continue. The correct answer is D. At 1 and 5 minutes after birth. D is correct because APGAR scoring is done at 1 and 5 minutes after birth to evaluate the newborn's heart rate, breathing, tone, reflexes, and color during the transition to life. A is wrong because APGAR scoring uses set early time points, not an hour of repeated checks. B is wrong because a single score does not capture how the newborn adapts over the first minutes. C is wrong because the standard times are 1 and 5 minutes, not 30 and 60 minutes. The APGAR score gives every birth attendant a shared, rapid language for a newborn's condition in the very first moments of life. It captures how well the baby is making the transition from womb to breathing on its own. 5 signs are assessed: heart rate, respiratory effort, muscle tone, reflex response to stimulation, and color. Each sign earns 0, 1, or 2 points, giving a possible total of 0 to 10. The score is recorded at 1 minute and again at 5 minutes after birth. The 1 minute reading reflects the newborn's condition right at delivery, while the 5 minute reading shows how well adaptation is progressing and correlates more strongly with true recovery. A score that climbs from the first reading to the second shows the transition is progressing, the common and reassuring pattern. If the newborn remains depressed, scoring continues every 5 minutes up to 20 minutes to track the response over time. The APGAR score is a snapshot that guides immediate attention, not a measure of long-term health. Resuscitation never waits for a score, and the standard timing never changes, 1 minute and 5 minutes after birth. Question 21. A nurse is teaching a client who is not breastfeeding about comfort measures for engorgement. Which instruction should the nurse include? Your options are: A. Wear a supportive bra continuously. B. Express milk to relieve fullness. C. Apply warmth to the breasts. D. Massage the breasts often. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is A. Wear a supportive bra continuously. A is correct because a client who is not breastfeeding wears a supportive bra and avoids stimulation so milk production decreases. Cold compresses and avoiding warmth also help suppress it. B is wrong because expressing milk signals the body to make more, which prolongs engorgement. C is wrong because warmth stimulates milk flow, which is undesirable when suppressing lactation. D is wrong because massage stimulates the breasts and encourages milk production rather than suppressing it. When a client chooses not to breastfeed, the nursing goal becomes suppressing milk production as quickly and comfortably as possible. Every care measure serves a single aim: remove the signals that tell the breast to keep making milk. Milk production runs entirely on supply and demand. The breast refills when it is emptied and stimulated. Leave it full and unstimulated. And rising internal pressure signals the body to slow production until it stops completely and the milk is reabsorbed. The anchor instruction is a firm supportive bra worn around the clock. It holds the breasts still without stimulation, limiting engorgement discomfort as production fades. Cold compresses and chilled cabbage leaves reduce swelling and dull the ache without triggering any milk-letting reflex. 4 things work against suppression. Expressing or pumping empties the breast and signals it to refill. Warmth encourages letdown and flow. Massage stimulates further production. And a loose bra allows movement that mimics stimulation. Each one tells the breast to make more milk, the opposite of the goal. The engorgement that peaks in the first few days is uncomfortable but self-limiting. As long as stimulation is avoided, the unstimulated breast reabsorbs the milk and production quietly stops on its own. Question 22. A nurse is preparing a client for internal fetal monitoring with a spiral electrode. Which condition must be met before this can be placed? Your options are: A. Labor must not have started. B. The membranes must be ruptured. C. The cervix must be closed. D. The client must be standing. Which would you go with? Lock it in before the reveal. The correct answer is B. The membranes must be ruptured. B is correct because internal monitoring requires ruptured membranes and adequate cervical dilation, so the spiral electrode can attach to the fetal presenting part. A is wrong because internal monitoring is used during active labor, not before labor begins. C is wrong because the cervix must be dilated, not closed, for the electrode to reach the fetus. D is wrong because the client is positioned for a vaginal procedure, not standing. Internal fetal monitoring uses a spiral electrode attached directly to the fetal presenting part, giving the most accurate continuous heart rate reading available during labor. Understanding why it works, what and when it can be used, comes down to a few firm physical requirements. The electrode is a small wire that passes through the dilated cervix and attaches to the fetal scalp. For this path to be open, the membranes must already be ruptured. The intact bag of waters would otherwise block the device entirely. 3 conditions must be present. The membranes must be ruptured, the cervix must be dilated enough to admit the device, and the presenting part must be down and reachable. Together these confirm that active labor is genuinely underway. External monitoring can lose its signal due to maternal movement, body habitus, or an active fetus. Internal monitoring bypasses all of that noise by reading the heartbeat directly from the fetus, which is why it is chosen when a reliable, continuous trace is truly needed. Internal monitoring is a targeted tool used during active labor when closer surveillance is warranted. Never before labor begins and never through a closed cervix. Ruptured membranes remain the essential gateway that makes placement possible. Question 23E. A nurse is teaching a postpartum client who reports cramping that worsens during breastfeeding. How should the nurse describe these afterpains to the client? Your options are A. Pain from a full bladder only. B. An indication of hemorrhage. C. Cramping from the uterus contracting. D. A sign of serious infection. Don't overthink it. Which one feels right? The correct answer is C. Cramping from the uterus contracting. C is correct because afterpains are cramping caused by the uterus contracting as it returns to its pre-pregnancy size, and they often intensify during breastfeeding. A is wrong because afterpains come from uterine contraction, though a full bladder can add discomfort. B is wrong because afterpains are expected cramping rather than an indication of hemorrhage. D is wrong because afterpains are a normal part of involution, not a sign of infection. After birth, the uterus must shrink from the size that held a full-term baby back down to the size of a fist, a process called involution. The cramping a client feels during this time is called afterpains, and it is a completely normal part of recovery. Those contractions are doing double duty. They shrink the uterine muscle and clamp down the blood vessels at the site where the placenta detached, which protects against postpartum blood loss. The cramping is the muscle doing exactly what it should. When a newborn suckles, the stimulation triggers a surge of oxytocin from the pituitary. That single hormone causes both milk letdown in the breast and stronger uterine contractions at the same time, which is why afterpains often intensify during or just after a feeding. Afterpains tend to be more noticeable in clients who have given birth before, because the uterus has less resting tone and must work harder to firm up. A full bladder can add to the discomfort, so keeping the bladder empty helps. But the source of the cramping is always the uterine muscle, not the bladder. The key takeaway is that afterpains are not a sign of hemorrhage, infection, or bladder trouble. They are the uterus contracting normally during involution, intensified by the same oxytocin that nourishes the baby through breastfeeding. Naming them correctly turns a worrying sensation into an expected one. Question 24. A nurse is reviewing a client's Bishop score before a planned labor induction. How should the nurse explain what this score helps determine? Your options are A. The position of the placenta, B. The client's pain level, C. Fetal lung maturity, D. Cervical readiness for induction. Got a guess? Lock it in. The correct answer is D. Cervical readiness for induction. D is correct because the Bishop score rates cervical factors to estimate how favorable the cervix is, which helps determine the likelihood that an induction will succeed. A is wrong because placental position is determined by ultrasound rather than by the Bishop score. B is wrong because the Bishop score evaluates the cervix, not the client's level of pain. C is wrong because fetal lung maturity is assessed through amniotic fluid studies, not the Bishop score. The Bishop score is a clinical tool used before inducing labor. It tells providers how ready the cervix is for induction, not by guessing, but by rating specific physical features and adding them into a single number. The score rates 5 cervical features: dilation, effacement, consistency, position, and fetal station. A cervix that is open, thinning, soft, pointing forward, and with the baby well descended earns a high score, around 8 or above, and is considered favorable for induction. Visually, a ripe cervix looks and feels different from an unripe one. It has already begun the softening, thinning, and opening that birth requires. Scoring those changes lets clinicians estimate success before committing to induction. A critical point, the Bishop score only measures cervical readiness. Placental position comes from ultrasound. Pain is reported by the client, and fetal lung maturity is assessed through amniotic fluid analysis. Assigning the score to any of those is the most common mistake on exam questions. Question 25. A nurse is teaching a client at her first prenatal visit about expected skin changes during pregnancy. Which finding should the nurse describe as normal? Your options are A. A dark line down the abdomen, B. Pale, cool skin, C. Yellowing of the skin, D. Widespread bruising. Which one is it? Pause the video if you need more time. The correct answer is A. A dark line down the abdomen. A is correct because hormone changes cause a thin line down the midline of the abdomen called the linea nigra, which is an expected and harmless change of pregnancy. B is wrong because pale, cool skin suggests poor circulation rather than the increased pigmentation typical of pregnancy. C is wrong because yellow-tinged skin can point to a liver problem and is not a normal change to expect during pregnancy. D is wrong because widespread bruising may signal a clotting concern and is not an ordinary skin finding in pregnancy. The linea nigra is a dark line running down the center of the abdomen during pregnancy. It marks where the abdominal muscles meet along the midline, and it is a completely normal, harmless change that fades on its own after birth. The line forms because rising pregnancy hormones stimulate melanin-producing cells in the skin. The midline of the abdomen, which may have been faintly visible or invisible before pregnancy, deepens into this brownish line. The same hormonal process also darkens the areolae and can cause pigmented patches on the face. Recognizing what is normal requires knowing what is not. Yellowing of the skin signals jaundice and a possible liver problem. Pale, cool skin points to poor circulation. Widespread bruising raises concern for a clotting disorder. Each of those findings needs investigation. The linea nigra does not. When a client asks about skin changes in pregnancy, the nurse can confidently describe the linea nigra as expected pigmentation caused by pregnancy hormones, knowing it well enough to set it apart from jaundice, poor perfusion, and clotting concerns is exactly the point. Question 26. A nurse is caring for a client immediately after an amniotomy. Which finding should the nurse report to the provider? Your options are A fetal heart rate of 140, B, green-tinged amniotic fluid, C, mild increase in contractions, D, clear watery amniotic fluid. Take a second. Which answer would you pick? The correct answer is B, green-tinged amniotic fluid. B is correct because green-tinged fluid indicates meconium, which can signal fetal stress, so the nurse reports it and prepares for possible newborn resuscitation at birth. A is wrong because a fetal heart rate of 140 is within the normal range and is reassuring. C is wrong because contractions commonly increase after an amniotomy, which is an expected effect. D is wrong because clear watery fluid is the expected normal finding after rupture of membranes. When membranes rupture, the color of amniotic fluid carries important clinical information. Normal fluid is clear or pale straw colored, so green-tinged fluid immediately stands out as something worth reporting. Meconium is the dark, sticky first stool that fills the fetal intestines during pregnancy. When a fetus experiences stress, often from reduced oxygen, the bowel can release meconium into the surrounding fluid, turning it green or greenish-brown. Meconium-stained fluid raises two concerns at once. It may reflect a stress event the fetus has already experienced, and it creates a new risk. If the newborn gasps and inhales the thick material, it can block airways and irritate lung tissue, a condition called meconium aspiration. Because of this dual risk, green fluid changes how the team prepares for delivery. The nurse reports the finding to the provider, staff readies equipment to clear the newborn's airway, and skilled resuscitation support is placed on standby or before the baby is born. Green-tinged fluid does not guarantee harm, but it raises the index of suspicion enough to change the entire preparation for birth. Reporting it promptly ensures the right people and equipment are present when they are needed most. Question 27. A nurse is caring for a client who reports she is unable to urinate several hours after a vaginal birth. Why is it important for the nurse to address this finding? Your options are A, it has no effect on bleeding, B, it prevents normal lochia, C, a full bladder can lead to uterine atony, D, a full bladder speeds involution. Before I reveal it, which one do you think is right? The correct answer is C. A full bladder can lead to uterine atony. C is correct because a distended bladder pushes the uterus up and to the side and keeps it from contracting, which can lead to uterine atony and increased bleeding. A is wrong because a full bladder does affect bleeding by preventing the uterus from contracting. B is wrong because bladder fullness is unrelated to the normal flow of lochia. D is wrong because a full bladder slows involution rather than speeding it. After a vaginal birth, the uterus must stay firmly contracted to control bleeding. A full bladder can quietly undermine that contraction, and understanding exactly how that happens is the key concept here. The bladder sits just below and in front of the uterus. When it fills, it physically shoves the uterus upward and off to one side, displacing it from its midline position. A displaced uterus simply cannot clamp down with full force. The mechanism follows a direct chain. A distended bladder displaces the uterus, leading to uterine atony, the state where the muscle stays soft and relaxed. A tonic uterine muscle cannot pinch the open blood vessels closed, and hemorrhage follows. When the placenta separates, it leaves a raw area laced with open blood vessels. The only seal is the uterine muscle squeezing tightly around them. If atony prevents that firm squeeze, those vessels keep bleeding, making atony the leading cause of postpartum hemorrhage. This is why the nurse cannot ignore a client who has not voided. Emptying the bladder by voiding or catheterization removes the obstruction, lets the uterus return to midline, and restores the firm contraction that prevents hemorrhage. Question 28. A nurse is teaching a postpartum client about strengthening the pelvic floor muscles after a vaginal birth. Which exercise should the nurse recommend? Your options are A. Abdominal crunches, B. Deep knee bends, C. Heavy weightlifting, D. Kegel exercises. What's your answer? Commit to one before I continue. The correct answer is D. Kegel exercises. D is correct because Kegel exercises tighten and relax the pelvic floor muscles, which improves muscle tone and bladder control during postpartum recovery. A is wrong because abdominal crunches target the abdomen and are postponed in early recovery, especially after a cesarean. B is wrong because deep knee bends work the legs rather than the pelvic floor muscles. C is wrong because heavy weightlifting strains healing tissues and does not strengthen the pelvic floor. After a vaginal birth, the pelvic floor muscles, the muscular sling supporting the bladder, uterus, and bowel, are stretched and weakened. Kegel exercises are the targeted way to rebuild that strength during early postpartum recovery. The pelvic floor forms the base of the pelvis and holds the bladder, uterus, and bowel up against gravity. When the sling loses tone after birth, it shows up as urine leaking with a cough, a sense of heaviness, or reduced organ support over time. To perform a Kegel, the client contracts the muscles she would use to stop urine midstream, holds the squeeze briefly, then relaxes, repeating the cycle in sets throughout the day. No equipment is needed, so it can be done almost anywhere. Kegels are the right choice because they isolate exactly the correct muscle group without stressing tissues that are still healing. Crunches target the abdomen, knee bends work the legs, and heavy lifting strains healing tissue. None of these restore pelvic floor tone. Done consistently, Kegels restore pelvic floor tone, improve bladder control, and address the root cause of postpartum weakness, making them the ideal gentle exercise to begin right after a vaginal birth. Question 29. A nurse is caring for a client in the first trimester who has light vaginal spotting, mild cramping, and a closed cervix. Which type of spontaneous abortion should the nurse suspect? Your options are A. Threatened, B. Incomplete, C. Missed, D. Complete. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is A. Threatened. Is correct because slight bleeding with mild cramping and a cervix that remains closed describes a threatened abortion, where the pregnancy may still continue with careful monitoring. B is wrong because an incomplete abortion involves heavy bleeding and a dilated cervix with some products of conception already passed. C is wrong because a missed abortion is fetal death with retained tissue and a closed cervix, typically without the active bleeding seen here. D is wrong because a complete abortion means all products of conception have passed and the cervix has closed afterward, not slight early spotting. When bleeding occurs in early pregnancy, clinicians classify the situation based on two key findings: whether the cervix is open or closed, and how much tissue has passed. These two facts determine the type of spontaneous abortion and what may happen next. The cervix is the gatekeeper. In a threatened abortion, light bleeding is present but the cervical ooze remains closed, meaning the pregnancy is at risk but has not been lost. As long as the cervix stays shut, there is still a chance the pregnancy will continue. Walking the spectrum shows how each type differs. Threatened has a closed cervix with slight bleeding. Inevitable brings an open dilating cervix. Incomplete means some tissue has passed. Complete means all tissue has passed. Missed means fetal death with retained tissue and a closed cervix, typically without active bleeding. The signal findings for threatened abortion are four: a closed cervix, light bleeding, mild cramping, and a pregnancy that may still survive. If you see first trimester spotting with mild cramps and a closed cervix, the answer is threatened, not inevitable, incomplete, complete, or missed. Question 30. A nurse is teaching a postpartum client about resuming exercise after a vaginal birth. Which instruction should the nurse include? Your options are A. Do only heavy lifting for strength. B. Begin with gentle exercises and progress gradually. C. Start vigorous workouts immediately. D. Avoid all activity for 6 weeks. Which would you go with? Lock it in before the reveal. The correct answer is B. Begin with gentle exercises and progress gradually. B is correct because the client begins with gentle exercises such as pelvic floor strengthening and progresses gradually, which supports recovery without straining healing tissues. A is wrong because heavy lifting is discouraged in early recovery and is not a starting exercise. C is wrong because vigorous workouts right away can strain healing tissues and increase bleeding. D is wrong because gentle activity and walking are encouraged early rather than avoiding all movement. After a vaginal birth, the body needs time to heal before returning to normal activity. The key principle is simple. Begin gently and build up gradually, letting the body set the pace. Several systems are recovering at once. Abdominal and pelvic floor muscles have been stretched. Perineal tissue may still be healing, and the cardiovascular and musculoskeletal systems are unwinding from the changes of pregnancy. Pushing too hard too soon risks straining all of these. Early activity starts with short walks and pelvic floor exercises. Walks support circulation and help prevent blood clots that immobility encourages. Pelvic floor work rebuilds the support stretched by delivery. From that base, intensity increases only as comfort and healing allow. The pelvic floor muscles and surrounding structures bear the most direct impact of vaginal delivery. Targeted pelvic floor exercises begin rebuilding this foundational support early, protecting the bladder, uterus, and bowel as healing progresses. The traps sit at the extremes. Heavy lifting or immediate vigorous workouts strain healing tissue and can increase bleeding. 6 weeks of complete rest ignores the real benefits of early gentle movement. The safe middle path is gentle activity that builds gradually over time. Question 31. A nurse is caring for a client in labor and finds a pulsating cord protruding from the vagina. Which action should the nurse take first? Your options are A. Place the client in high Fowler position. B. Push the cord back inside. C. Lift the presenting part off the cord. D. Leave to call the provider. Don't overthink it. Which one feels right? The correct answer is C. Lift the presenting part off the cord. C is correct because with a prolapse cord, the nurse uses a gloved hand to lift the presenting part off the cord, relieving compression and protecting fetal blood flow until birth. A is wrong because a knee chest or Trendelenburg position, not high Fowler, helps relieve cord pressure. B is wrong because pushing the cord back can damage it and worsen compression. D is wrong because the nurse must stay and relieve the pressure while calling for help, not leave the client. A prolapsed umbilical cord is one of labor's true emergencies. When the cord slips ahead of the presenting part, it gets trapped between the baby and the bony pelvis, and every contraction squeezes it tighter, cutting off fetal oxygen fast. The cord is the fetus's only lifeline, carrying oxygenated blood to the baby. When it prolapses, the presenting part pins it against the bony pelvis. The nurse's gloved hand lifts that presenting part upward. That single mechanical action stops the compression and buys time for delivery. 3 actions happen simultaneously. The gloved hand lifts the presenting part off the cord and does not let go until delivery. The client is repositioned into knee chest or steep head down tilt, so gravity shifts fetal weight away from the cord. Help is summoned without ever withdrawing the hand. 4 responses actively fail the fetus. Pushing the cord back risks spasm and worsens compression. High Fowler does nothing to lift fetal weight. Leaving the bedside removes the only protection. And handling the cord causes spasm. Instead, keep it warm and moist. The core principle is mechanical. Compression causes the crisis, so decompression is the fix. The hand lifts. The team mobilizes, and the position uses gravity, all while the hand never leaves until the baby is delivered. Question 32. A nurse is teaching a pregnant client about food safety to reduce the risk of toxoplasmosis. Which instruction should the nurse include? Your options are A. Drink unpasteurized milk. B. Eat more rare meat. C. Skip washing produce. D. Avoid changing the cat litter box. Got a guess? Lock it in. The correct answer is D. Avoid changing the cat litter box. D is correct because toxoplasmosis can spread through cat feces, so the client should avoid changing the litter box during pregnancy to lower the risk of infecting the fetus. A is wrong because unpasteurized milk can carry harmful organisms and should be avoided during pregnancy. B is wrong because rare or undercooked meat can transmit toxoplasmosis, so the client should eat meat that is thoroughly cooked. C is wrong because washing produce removes possible contamination, so skipping it would raise rather than lower the risk. Toxoplasmosis is a parasitic infection that poses little danger to healthy adults but can seriously harm a developing fetus. Because the mother may feel only mild flu-like symptoms or nothing at all. Prevention is far more important than watching for warning signs. A first-time infection during pregnancy allows the parasite to cross the placenta and cause congenital toxoplasmosis, which can damage the developing brain and eyes and lead to lasting problems for the baby. The parasite spreads through 4 main routes: cat feces, raw or undercooked meat, unwashed produce, and contaminated soil. Every prevention strategy is aimed at closing off one of these pathways. Infected cats shed parasite eggs in their feces, and those eggs become infectious if the litter sits long enough. The safest approach is to have someone else change the box entirely, but if that is not possible, daily cleaning with gloves and thorough hand washing greatly reduces the risk. Each safe behavior, skipping litter duty, cooking meat thoroughly, and washing produce, closes one route the parasite uses to reach the fetus. Doing the opposite, such as eating rare meat or skipping produce washing, reopens that risk. Question 33. A nurse observes abrupt drops in the fetal heart rate that vary in timing with contractions. Which intervention should the nurse perform first? Your options are A. Reposition the client. B. Prepare for immediate forceps. C. Increase the oxytocin. D. Place the client flat. Which one is it? Pause the video if you need more time. The correct answer is A. Reposition the client. A is correct because variable decelerations usually come from cord compression, so repositioning the client first often relieves pressure on the cord and improves the fetal heart rate. B is wrong because forceps are not the first response. Relieving cord pressure with position change comes first. C is wrong because increasing oxytocin strengthens contractions and can worsen cord compression. D is wrong because lying flat can lower blood pressure and does not relieve the cord compression causing the pattern. Variable decelerations are abrupt, inconsistent drops in fetal heart rate, and understanding why they happen tells you exactly what to do first. Fetal heart rate patterns are sorted by their timing relative to contractions. Early decelerations mirror contractions and reflect head compression, benign. Late decelerations start after the peak and signal placental blood flow problems. Variable decelerations are abrupt and inconsistent, and they point to cord compression. Cord compression occurs when the umbilical cord is squeezed between the fetus and the uterine wall. Each pinch briefly cuts blood flow, causing a sharp heart rate drop. Because compression is positional and unpredictable, the pattern varies in shape and timing with each occurrence. The response always starts with the simplest, fastest, least invasive step: repositioning the client. Turning her side to side or into a knee-chest position can lift fetal weight off the cord and restore flow. Only if repositioning fails do you escalate to IV fluids, oxygen, or a vaginal exam to rule out prolapsed cord. The key reasoning is straightforward. Variable decelerations mean cord compression, and cord compression is a position problem. Repositioning comes first, before oxytocin, before forceps, and never by laying the client flat. Question 34. A nurse is caring for a client in labor whose fetal heart rate shows recurrent late decelerations after repositioning and stopping oxytocin. Which action should the nurse take next? Your options are: A. Place the client supine. B. Give oxygen by face mask. C. Encourage the client to push. D. Restart the oxytocin. Take a second. Which answer would you pick? The correct answer is B. Give oxygen by face mask. B is correct because when late decelerations persist after repositioning and stopping oxytocin, the nurse gives oxygen by face mask to improve the oxygen available to the fetus. A is wrong because the supine position can lower blood pressure and reduce placental flow further. C is wrong because pushing does not address the reduced placental oxygen causing late decelerations. D is wrong because restarting oxytocin would intensify contractions and worsen the decelerations. Late decelerations signal that the placenta cannot deliver enough oxygen to the fetus during contractions. Understanding why they happen and how to respond requires knowing what uteroplacental insufficiency actually means. During every contraction, the vessels feeding the placenta are briefly compressed, dipping the oxygen supply. A healthy placenta has enough reserve to ride that out. When the placenta is already running low, from high blood pressure, aging, or excessive contractions, the fetus is pushed past its margin, and the heart rate sags late after the contractions peak. That delayed timing is the signature of uteroplacental insufficiency. The response is a stepwise approach called intrauterine resuscitation. First, reposition the client to her left side. Second, stop the oxytocin. Third, increase intravenous fluids. Fourth, give oxygen by face mask. Each step attacks the oxygen shortage from a different angle. So when repositioning and stopping oxytocin have already been done, oxygen is the logical next move. 3 actions make things worse. Placing the client supine drops blood pressure and cuts placental flow further. Encouraging pushing adds stress without helping oxygen delivery. Restarting oxytocin intensifies the very contractions causing the problem. Late decelerations that persist are a sign the fetus is at the edge of its reserve, and every intervention must move toward improving oxygen, not reducing it. Question 35. A nurse is caring for a client receiving oxytocin to augment labor. Which finding indicates the medication is having the desired effect? Your options are: A. Absent fetal heart tones. B. A continuously rigid uterus. C. Progressive cervical dilation. D. Contractions every minute. Before I reveal it, which one do you think is right? The correct answer is C. Progressive cervical dilation. C is correct because the goal of augmentation is effective labor, So progressive cervical dilation with a regular contraction pattern shows the oxytocin is working as intended. A is wrong because absent fetal heart tones is an emergency, not a desired effect. B is wrong because a uterus that never relaxes signals overstimulation and endangers the fetus. D is wrong because contractions every minute are too frequent and reduce fetal oxygen delivery. When oxytocin is used to augment labor, it works by strengthening and organizing contractions that have slowed or become ineffective. Understanding what success looks like and what danger looks like is the core of safe oxytocin management. Effective labor has 3 hallmarks. The cervix opens further at each exam. Contractions come at a productive but not excessive interval, and the uterus softens between squeezes. The goal is never the strongest or most frequent contractions, indeed. It is a pattern that does the work steadily. The rest between contractions is not wasted time. It is when the fetus is reoxygenated. That recovery window is why the nurse titrates oxytocin to the lowest dose that achieves steady progress, backing off if contractions crowd together or the uterus stops relaxing. Distinguishing the desired effect from overstimulation is critical. A steadily dilating cervix paired with uterine relaxation between contractions signals success. A continuously rigid uterus or contractions every minute signals overstimulation, dangerous patterns that cut into fetal oxygen supply and require the dose to be reduced. Progressive cervical dilation with a controlled contraction pattern is the picture of oxytocin working as intended. Any slide toward a rigid uterus, excessive frequency, or fetal distress means the dose has overshot the goal. Question 36. A nurse is teaching new parents about expected newborn skin findings. Which finding should the nurse describe as a normal variation? Your options are A. Widespread bruising, B. Yellow skin in the first day, C. Pale mottled skin, D. Small white spots on the nose. What's your answer? Commit to one before I continue. The correct answer is D. Small white spots on the nose. D is correct because small white spots on the nose and chin are melia, a normal newborn finding caused by blocked oil glands that disappear without treatment, so parents should not squeeze them. A is wrong because widespread bruising is not an expected skin finding and may signal a problem. B is wrong because yellow skin within the first day suggests pathologic jaundice that needs evaluation, not a normal variation. C is wrong because pale, mottled skin can indicate poor perfusion or cold stress rather than a normal variation. Milia are tiny white bumps that commonly appear on a newborn's nose, chin, and cheeks. They are a normal variation, not an infection, not a rash, and not a sign that anything is wrong. Milia form when keratin and oil become trapped just under the skin inside oil glands that haven't yet opened up. The trapped material shows through as a firm, pearly white bump, usually no bigger than a pinhead. Parents need 3 key pieces of reassurance. Milia are common and completely harmless. They resolve on their own over the first weeks of life, and the bumps should never be squeezed. Squeezing can injure delicate skin and introduce infection where none existed. Recognizing milia means being able to set them apart from findings that do need attention. Widespread bruising, yellow skin appearing on the first day of life, and pale or mottled skin are all abnormal findings that require evaluation, not reassurance. When a nurse confidently identifies milia, parents are reassured and no unnecessary treatment is started. The skill is knowing what to leave alone so that real concern can go where it belongs. Question 37. A nurse is teaching a pregnant client who follows a strict vegetarian diet. Which nutrient should the nurse emphasize may need supplementation? Your options are A. Vitamin B12, B. Sodium, C. Potassium, D. Vitamin A. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is A. Vitamin B12. A is correct because vitamin B12 is found mainly in animal products. So a client on a strict vegetarian diet may need a supplement to meet the increased needs of pregnancy. B is wrong because sodium is plentiful in most diets and is not a nutrient that a vegetarian pregnant client typically lacks. C is wrong because potassium is abundant in fruits and vegetables, making a deficiency unlikely on a vegetarian diet. D is wrong because vitamin A is available from many plant foods, so deficiency is not the main concern with a vegetarian diet. When a pregnant client follows a strict vegetarian diet, one nutrient stands out as the critical gap. Vitamin B12 is almost entirely sourced from animal products, making it uniquely vulnerable in a plant-only diet. B12 is irreplaceable. It forms healthy red blood cells, builds and maintains the nervous system, and supports fetal neurologic development, because the body stores but cannot manufacture B12. Consistent dietary intake is essential, and pregnancy raises that demand even further. Vitamin B12 is produced by microorganisms and concentrated into animal products. Meat, fish, poultry, eggs, and dairy are the reliable sources. Plant foods supply no usable B12 unless fortified, which is why a strict vegetarian diet structurally closes off the natural supply. Common distractors name nutrients that plant foods supply well. Sodium is plentiful in most diets. Potassium is abundant in fruits and vegetables, and vitamin A is available from many plant sources. Vitamin B12 is the one nutrient that plants simply do not provide in usable amounts. This signals a strict vegetarian or vegan diet during pregnancy. The nursing response is to identify B12 as the structural gap and ensure the client uses a supplement or reliably fortified foods to protect both herself and her developing baby. Question 38. A nurse is teaching a client who is positive for HIV about caring for her newborn after birth. Which instruction should the nurse include? Your options are A. Skip the newborn's medications. B. Avoid breastfeeding the newborn. C. Breastfeed exclusively for 6 months. D. Share feeding utensils freely. Which would you go with? Lock it in before the reveal. The correct answer is B. Avoid breastfeeding the newborn. B is correct because HIV can pass to the newborn through breast milk, so the client is taught to avoid breastfeeding and use formula to lower the risk of transmission. C is wrong because the newborn receives prescribed antiviral medication after birth, which should not be skipped. C is wrong because breastfeeding can transmit HIV, so it is avoided rather than encouraged for these newborns. D is wrong because the concern is breast milk transmission, and the priority teaching is to avoid breastfeeding, not utensil sharing. When a mother is HIV positive, one of the most important goals is preventing the virus from passing to her newborn. This is called perinatal or vertical transmission, and several targeted steps work together to reduce that risk. The virus travels in certain body fluids, and breast milk is one of them. An HIV-positive mother who breastfeeds exposes her baby to the virus over weeks or months of feeding. When safe formula is available, switching to formula closes off this route entirely. Feeding choice is just one part of a 4-part prevention package. The mother takes antivirals during pregnancy to lower her viral load. The birth is managed to limit the baby's exposure, and the newborn receives its own antiviral course after birth. Together, these steps have made mother-to-child transmission far less common. 3 common missteps undercut the plan. Skipping the newborn's prescribed antivirals removes a critical preventive step. Encouraging breastfeeding reintroduces the very exposure the plan avoids. And worrying about shared utensils distracts from the real concern. Breast milk is the transmission route, not casual contact. When safe formula is available, the risk of transmission through breast milk is simply not worth taking. Formula feeding, combined with antiviral medication for both mother and newborn, gives the baby the best possible chance of remaining uninfected. Question 39. A nurse is teaching a client who has preeclampsia about her home environment. Which instruction should the nurse include? Your options are A. Use bright overhead lighting. B. Invite frequent loud visitors. C. Keep the room quiet and dim. D. Play loud music for stimulation. Don't overthink it. Which one feels right? The correct answer is C. Keep the room quiet and dim. C is correct because a quiet, dim environment reduces stimulation that could trigger a seizure. So the nurse teaches the client to limit noise and bright light at home. Is wrong because bright lighting is a stimulus that should be reduced, not increased. B is wrong because frequent loud visitors increase stimulation, which raises the risk of a seizure. D is wrong because loud music adds stimulation and works against the goal of a calm environment. Preeclampsia is a pregnancy disorder marked by high blood pressure and signs of organ stress. One of the most serious risks is progression to eclampsia, seizures that are dangerous for both mother and fetus. The disorder involves elevated blood pressure and protein spilling into the urine. As it worsens, warning signs like headache, visual changes, an upper abdominal pain signal that the nervous system is approaching a dangerous threshold. An already irritable nervous system can be pushed over the seizure threshold by environmental stimulation. Bright light, loud noise, and a busy setting are all provocations that raise the risk of triggering a seizure. The standard teaching is to keep the environment quiet and dim. Dim lighting, limited noise, and restricted visitors all reduce stimulation, giving the irritable nervous system less to react to and lowering the chance a seizure is triggered. Every piece of environmental advice points the same direction: less stimulation. Paired with medications that lower blood pressure and raise the seizure threshold, a calm and restful home environment is a direct protective measure against eclampsia. Question 4. A nurse is reviewing prenatal laboratory work and notes the client is not immune to rubella. Which action should the nurse anticipate? Your options are A. Give the vaccine during pregnancy. B. Schedule weekly titers. C. Begin antiviral therapy now. D. Plan vaccination after birth. Got a guess? Lock it in. The correct answer is D. Plan vaccination after birth. D is correct because the rubella vaccine is a live virus and is not given during pregnancy, so a non-immune client is vaccinated after birth to protect future pregnancies. A is wrong because the live rubella vaccine is avoided during pregnancy due to potential risk to the fetus. B is wrong because weekly titers are unnecessary, since the plan is simply to vaccinate the client in the postpartum period. C is wrong because antiviral therapy is not the approach for rubella non-immunity. Vaccination after birth is the plan. When prenatal labs show a client is not immune to rubella, there is a specific chain of clinical reasoning the nurse must follow. Understanding why that chain exists starts with what rubella immunity actually means. A non-immune result means the blood test found no protective antibodies against rubella. The client was never vaccinated or never had the infection, so her immune system would not recognize the virus if she encountered it. The stakes are high because if a non-immune client contracts rubella during pregnancy, the virus can cross the placenta. This can cause congenital rubella syndrome, a serious cluster of defects affecting the baby's heart, eyes, ears, and brain. The rubella vaccine is a live virus vaccine, which means it cannot be given safely during pregnancy. The plan is to administer the dose before hospital discharge after delivery, protecting all future pregnancies. Reading the lab, recognizing what non-immune means, and anticipating the postpartum dose is the full chain. Vaccinating during pregnancy, repeating titers, or starting antivirals all miss the mark entirely. Question 41. A nurse is caring for a newborn whose parent had gestational diabetes. Which complication should the nurse monitor for in the newborn? Your options are A. Low blood glucose, B. High blood pressure, C. Low birth weight, D. Delayed first breath. Which one is it? Pause the video if you need more time. The correct answer is A. Low blood glucose. A is correct because the newborn of a parent with diabetes is at risk for low blood glucose after birth, because high fetal insulin levels continue once the maternal glucose supply stops. B is wrong because high blood pressure is not the typical newborn risk linked to maternal diabetes. C is wrong because these newborns tend to be large rather than small due to extra fetal growth from high glucose. D is wrong because A. Delayed first breath is not the specific concern. The priority is monitoring blood glucose. When a parent has diabetes during pregnancy, their newborn faces a specific risk in the first hours of life. And the reason is rooted in how the fetus adapted to a high glucose environment in the womb. Glucose crosses the placenta freely, bathing the fetus in extra sugar whenever the parent's blood glucose runs high. Insulin does not cross, so the fetal pancreas ramps up its own production to compensate, and over time it learns to make very high levels of insulin. At birth, the umbilical cord is clamped and the glucose supply stops instantly, but the newborn's pancreas does not switch off as quickly. It keeps releasing the high insulin levels it grew used to making, and that insulin drives blood sugar down. The result is neonatal hypoglycemia, low blood glucose in the first hours of life. If missed, it can harm the newborn's brain. Nurses respond by checking blood glucose levels and feeding the baby early to supply sugar from outside while the pancreas gradually recalibrates. The key reasoning to lock in: fetal insulin remains elevated after the glucose pipeline closes, making low blood glucose the priority concern. Not high blood pressure, low birth weight, or a delayed first breath. Question 40 is, a nurse is caring for a newborn who develops cold stress. Which complications should the nurse monitor for as a result? Your options are A. Increased appetite, B. Low blood glucose, C. High blood pressure, D. Slow heart rate. Take a second, which answer would you pick? The correct answer is B. Low blood glucose. B is correct because cold stress raises the newborn's oxygen and energy demands, which can use up glucose stores and lead to low blood glucose along with acidosis. A is wrong because a stressed cold newborn tends to feed poorly, not show increased appetite. C is wrong because cold stress is linked with metabolic problems rather than high blood pressure. D is wrong because cold stress increases the respiratory rate and metabolic demand rather than slowing the heart. When a newborn gets cold, the body launches a costly warming response. Understanding why requires a look at how newborns generate heat and what that process burns through. Newborns are especially vulnerable to heat loss for 3 reasons: their large surface area to body ratio, thin skin with minimal insulating fat, and, critically, they cannot shiver. Shivering is the primary heat-making tool for older children and adults, but it is simply unavailable to a newborn. Instead of shivering, newborns rely on brown fat, a specialized tissue that generates heat through a process called non-shivering thermogenesis. Breaking down brown fat consumes both oxygen and glucose. which is manageable briefly but becomes costly when cold stress is sustained. When cold stress continues, the warming machinery runs hard and three complications emerge. Glucose is depleted as it fuels thermogenesis. Oxygen demand rises beyond available supply, and the resulting oxygen debt pushes the body toward acidosis. All three branch from one trigger, the effort to stay warm. This is why newborn warmth is clinical, not just comfort. Drying the baby, applying a cap, and using skin-to-skin contact prevent cold stress before it starts, keeping glucose reserves intact and oxygen demand low. Question 43. A nurse is caring for a client who has a positive pregnancy test and reports a previous pregnancy that ended at 10 weeks. Which information is most important for the nurse to obtain? Your options are A. Preferred room temperature, B. Favorite foods, C. A complete obstetric history, D. Exercise brand preferences. Before I reveal it, which one do you think is right? The correct answer is C. A complete obstetric history. C is correct because A. Complete obstetric history reveals past losses, complications, and outcomes that shape current risk and guide the plan of care for this pregnancy. A is wrong because room temperature preference has no bearing on assessing the client's reproductive history or current risk. B is wrong because food preferences, while useful for later diet teaching, are not the priority when establishing pregnancy risk. D is wrong because exercise brand preferences are irrelevant to the obstetric history the nurse needs to gather first. When a newly pregnant client mentions a previous pregnancy that ended early, the nurse's first move is to gather a complete obstetric history. That record of past pregnancies and their outcomes is the foundation everything else is built on. Clinicians organize obstetric history using a shorthand called GT takes from counting total pregnancies, term births, preterm births, losses, and living children. Every prior pregnancy and how it ended gets captured in this record. The reason obstetric history takes priority is that the past predicts the present in obstetrics. A history of early loss, preterm birth, or complications flags risks that directly change how closely this pregnancy is watched and what care is planned. The common missteps in these scenarios offer information about comfort, food, or personal preferences, none of which affect reproductive risk or the plan of care. Only the complete obstetric history captures what the nurse most needs to know first. This reflects a broader rule of nursing prioritization. Reach first for the information that most affects safety and guides care. For a newly pregnant client with a history of loss, that means the obstetric history every time. Question 44. A nurse is caring for a client who has a molar pregnancy. Which finding should the nurse expect? Your options are A. Decreased nausea and vomiting, B. A strong fetal heart rate, C. Lower than normal blood pressure, D. Abnormally high pregnancy hormone levels. What's your answer? Commit to one before I continue. The correct answer is D. Abnormally high pregnancy hormone levels. D is correct because a molar pregnancy produces abnormally high pregnancy hormone levels because the abnormal placental tissue overgrows, which also drives severe nausea and rapid uterine enlargement. A is wrong because the high hormone levels usually cause excessive nausea and vomiting rather than reducing it. B is wrong because a molar pregnancy has no viable fetus, so a fetal heart rate is not present. C is wrong because the condition is linked with early high blood pressure, not low blood pressure. A molar pregnancy, also called a hydatidiform mole, is an abnormal overgrowth of placental tissue instead of a normal pregnancy. The key to understanding this condition is knowing what that overgrown tissue does to a single hormone. Instead of a placenta and fetus, the uterus fills with a mass of fluid-filled sacs resembling a cluster of grapes. This abnormal tissue behaves like placental tissue and pumps out human chorionic gonadotropin, far beyond normal pregnancy levels. The flood of HCG drives the entire clinical picture: severe nausea and vomiting, a uterus that grows faster than expected, early onset high blood pressure, and vaginal bleeding. Critically, there is no fetal heartbeat because there is no viable fetus. Treatment means removing the abnormal tissue, then following HCG levels over time until they fall to zero. Because the tissue can persist or regrow, that same hormone becomes the marker for confirming complete recovery. Everything in a molar pregnancy traces back to one fact: abnormal placental-type tissue overproduces HCG. High HCG explains the symptoms. The absent heartbeat confirms no viable fetus, and falling HCG confirms successful treatment. Question 45. A nurse is teaching a client at 36 weeks of gestation about Group B streptococcus screening. How should the nurse explain its purpose? Your options are: A. It guides antibiotics to protect the newborn. B. It confirms fetal lung maturity. C. It estimates the birth weight. D. It measures the client's glucose. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is A. It guides antibiotics to protect the newborn. A is correct because screening identifies carriers so the client can receive antibiotics during labor, which protects the newborn from a serious Group B streptococcus infection at birth. B is wrong because lung maturity is assessed through amniotic fluid studies rather than this culture. C is wrong because birth weight is estimated by ultrasound, not by a vaginal and rectal culture. D is wrong because glucose is checked through separate testing, not the Group B streptococcus culture. Group B streptococcus screening near the end of pregnancy isn't about diagnosing illness in the parent. It's about protecting the baby. Understanding why the screen is done and what it triggers is the core of this concept. Group B streptococcus can colonize the vagina and rectum of a healthy person without causing any symptoms. But at the moment of a vaginal birth, the newborn passes through that environment, and in a vulnerable infant, the bacteria can cause bloodstream infection, pneumonia, or meningitis. The screen is timed at 36 to 37 weeks, so the result reflects carrier status at delivery. A positive result means IV antibiotics are given during labor, which reduces bacterial exposure to the baby and sharply lowers the risk of early infection. This diagram shows how GBS passes from parent to newborn through the birth canal, and how intrapartum antibiotics interrupt that transmission before serious infection can take hold. The GBS screen has one purpose: identify carriers so antibiotics can be ready when labor begins. The parent is the carrier. The newborn is the one being protected. Question 46. A nurse is caring for a client in the taking-in phase during the first day after birth. Which client behavior should the nurse expect? Your options are: A. Focusing on the family as a unit. B. Focusing on her own needs and the birth. C. Refusing to hold the newborn. D. Confidently taking charge of all care. Which would you go with? Lock it in before the reveal. The correct answer is B. Focusing on her own needs and the birth. B is correct because in the taking-in phase, the client focuses on her own needs and often wants to talk about the birth, relying on others before she moves toward newborn care. A is wrong because focusing on the family as a unit describes the letting go phase that comes later. C is wrong because refusing to hold the newborn is a sign of impaired bonding, not a normal taking in behavior. D is wrong because confidently taking charge of care reflects the later taking hold phase, not taking in. After giving birth, mothers move through predictable stages as they adjust to their new role. Understanding these phases helps nurses provide the right support at the right time. The 3 phases are taking in, taking hold, and letting go. Each phase has its own typical behaviors, and the nurse's role shifts depending on which phase the mother is in. During taking in, which covers roughly the first day or 2, the mother is tired from labor and focused inward. She wants to rest, eat, and process what happened by retelling her birth story, and she leans on caregivers rather than taking charge of newborn care herself. As the mother recovers and regains energy, she moves into taking hold, becoming eager to learn and taking charge of newborn care with growing confidence. Eventually, letting go brings acceptance of the new role and an adjusted family identity. The key clinical insight is that a first-day mother who seems self-focused and relies on staff is behaving exactly as expected. The nurse's job is to support rest, listen to the birth story, and let active caregiving grow naturally as the mother moves forward. Question 47. A nurse is assessing a newborn and notes a fine rash with small pale bumps on a reddened base that appeared on the 2nd day. How should the nurse interpret this finding? Your options are: A. It is a serious skin infection. B. It is a sign of dehydration. C. It is erythema toxicum, a normal rash. D. It is an allergic reaction. Don't overthink it. Which one feels right? The correct answer is C. It is erythema toxicum, a normal rash. C is correct because a blotchy rash with small pale bumps appearing in the first days is erythema toxicum, a harmless newborn rash that clears on its own without treatment. A is wrong because this is a benign newborn rash, not a serious skin infection. B is wrong because this rash is unrelated to hydration status. D is wrong because erythema toxicum is a normal finding rather than an allergic reaction. Erythema toxicum is one of the most common rashes seen in newborns, and the most important thing to understand is that it is completely normal and harmless. It looks alarming, but it requires no treatment at all. The rash appears as small pale or yellow-white bumps sitting on patches of reddened skin, scattered across the face, trunk, and limbs. It typically shows up around the 2nd day of life as the newborn skin and immune system adjust to life outside the womb. The key reassuring features are that the newborn is otherwise entirely well, feeding normally, no fever, and no signs of illness. The rash itself is superficial and self-limiting, fading on its own within the first week of life. Because the rash resolves completely on its own, care is simply to leave it alone and reassure the parents. No creams, no antibiotics, no special handling. The nurse's role is to recognize it as normal and prevent unnecessary worry. The common traps are mistaking this normal rash for a skin infection, dehydration, or an allergic reaction. Each of those misclassifies a harmless expected newborn finding as a problem. Recognizing erythema toxicum confidently lets a nurse calm worried parents and reserve concern for findings that truly need it. Question 48. A nurse is caring for a client receiving terbutaline to suppress preterm labor. Which finding should the nurse report to the provider? Your options are: A. Blood pressure 116/70. B. Mild dry mouth. C. Occasional fetal movement. D. Heart rate of 132 per minute. Got a guess? Lock it in. The correct answer is D. Heart rate of 132 per minute. D is correct because terbutaline can cause a rapid maternal heart rate, so a rate above the expected range should be reported, since it may require holding the medication. A is wrong because this blood pressure is within normal limits and is not a concern. B is wrong because mild dry mouth is a minor side effect that does not require provider notification. C is wrong because fetal movement is a reassuring sign rather than an adverse effect of the medication. Terbutaline is used to suppress preterm labor by relaxing the uterus, but understanding why it also affects the heart is the key to safe monitoring. Terbutaline is a beta agonist, meaning it stimulates beta receptors throughout the body. Activating these receptors relaxes uterine smooth muscle, the intended effect, but the same receptors on the heart cause the rate to climb, which is the unavoidable trade-off. Some increase in heart rate, jitteriness, and tremor are known effects of the drug. The line is crossed when the resting maternal heart rate rises above roughly 120 beats per minute, signaling excessive cardiac stimulation that must be reported to the provider. Only one finding demands a provider call: a rapid maternal heart rate. Normal blood pressure, mild dry mouth, and reassuring fetal movement do not require notification. Catching that rise in heart rate early is what prevents progression to serious complications like pulmonary edema. The nurse's role is to recognize that the same action relaxing the uterus is capable of overstimulating the heart. When that threshold is reached, reporting it promptly lets the team decide whether to hold the medication before harm occurs. Question 49. A nurse is teaching a client who received the rubella vaccine before discharge after birth. Which instruction should the nurse include in the teaching? Your options are: A. Avoid pregnancy for 4 weeks. B. Repeat the dose next week. C. Breastfeeding must be stopped. D. Expect immunity to be lost. Which one is it? Pause the video if you need more time. The correct answer is A. Avoid pregnancy for 4 weeks. A is correct because the rubella vaccine is a live virus, so the client avoids pregnancy for about 4 weeks after receiving it to protect a future fetus. B is wrong because a single dose is given postpartum, not repeated the following week. C is wrong because breastfeeding is not contraindicated after the rubella vaccine. D is wrong because the vaccine provides immunity rather than causing it to be lost. After delivering a baby, a client who missed rubella immunity during pregnancy can finally receive the vaccine. Because it contains a live, weakened virus, one specific precaution applies, and understanding why it exists makes the teaching stick. A live attenuated vaccine works by introducing a weakened form of the real virus, provoking a genuine immune response. That same live virus is why the vaccine was held during pregnancy. A developing fetus must not be exposed to it, even in its weakened state. Once the baby is born, the dose can be given safely. For the following 4 weeks, the client avoids becoming pregnant, giving the live virus time to fully clear from her body. After that window, she carries lasting immunity and can conceive without concern. Common misunderstandings include repeating the dose the following week, stopping breastfeeding, or believing the vaccine reduces immunity. None of these are correct. Breastfeeding continues normally. One postpartum dose is all that is given, and the vaccine's entire purpose is to build protection, not remove it. The precaution is short and specific. Avoid pregnancy for about 4 weeks while the live virus clears. After that, the client is protected. Breastfeeding is unaffected, and healthy future pregnancies are exactly what the vaccine was meant to support. Question 50. A nurse is teaching a client with gestational diabetes about reducing fetal risk. Which client statement indicates understanding? Your options are: A. I will stop my exercise routine. B. I will keep my blood sugar controlled. C. I will avoid all checkups now. D. I will skip meals to lower sugar. Take a second. Which answer would you pick? The correct answer is B. I will keep my blood sugar controlled. B is correct because keeping blood glucose within target range lowers the risk of a large infant and newborn complications. So this statement shows the client understands her care. A is wrong because regular exercise helps control glucose, so stopping it works against the goal. C is wrong because frequent checkups are needed to monitor the client and fetus throughout the pregnancy. D is wrong because skipping meals can cause low blood glucose and ketones, which is unsafe for the fetus. Gestational diabetes raises blood sugar during pregnancy, and that extra glucose crosses the placenta directly to the fetus. Understanding why steady glucose control matters is the key to safe outcomes for both parent and baby. When maternal glucose is high, sugar crosses the placenta and the fetal pancreas responds by producing extra insulin. That insulin acts as a growth signal, leading to macrosomia, an unusually large infant, and setting up the newborn for low blood sugar after delivery. Uncontrolled blood sugar leads to 3 linked risks: macrosomia from excess fetal insulin, a difficult birth or birth injury due to the infant's size, and newborn hypoglycemia after delivery when the baby's high insulin keeps working without the maternal glucose supply. Achieving control rests on 4 habits working together: a balanced eating plan to prevent spikes, regular physical activity to help the body use glucose, frequent monitoring to confirm targets are met, and insulin or medication when diet and activity alone are not enough. Every healthy choice in gestational diabetes care connects back to one idea: steady blood glucose limits the extra sugar reaching the fetus, which reduces excess growth and newborn complications. A client who commits to glucose control has grasped the whole approach.
You have reached the end of our first question set. For the free complete exam preparation, visit our website, link in the description, where you find thousands more practice questions and comprehensive study guides. Thanks for studying with us today. See you in the next video.